We'll just give it like another minute or so, and then we'll open it up.
You could probably start letting people in. It's 12:59.
Okay.
Hi, Alethia.
Hi, Andrea.
How are you?
I'm great. Lisa and Andrea, if you'll help me to know if there are any questions in the chat, that'd be great.
Okay. All right.
Good afternoon, and welcome to the SEMPQIC sponsored web session on tools for the field, integrating equity into family health services. Please put your name and agency in the chat so we know who is with us today. I'm Alethia Carr, the lead consultant for health equity at SEMPQIC, and I'm the granddaughter of a midwife from Valdosta, Georgia. I believe all people are entitled to optimal health. I'll be conducting today's session, which will highlight 3 tools available to help improve integration of health equity into work in the perinatal care and service arena. Our agenda includes a brief overview of SEMPQIC to familiarize you with the coalition. I'll then highlight the CDC Health Equity Guiding Principles for Inclusive Communication. This information can be used by nearly anyone working to promote health equity, recognizing that communication is a major factor. I'll then review the AMA Advancing Health Equity Guide, which was recently published for use in clinical care settings. And I'll close out sharing aspects of the e-learning webinar from the Health and Human Service Office of Minority Health CLAS for Maternal Health. It's an online training offering 2 hours of continuing education, as well as considerable information on health equity in perinatal care. I have suggested recommendations for use of these tools that I'll leave with you. Questions and comments can be included in the chat as I speak, and I'll work to address them along the way. But I offer this caveat that you may have ideas for answers to questions posed as well. So we'll work together on that aspect of the session. We'll wrap up with a short evaluation for you to complete when we end this hour-long session. The The session is very timely, as just yesterday, Vice President Harris hosted the first ever White House Maternal Summit Day of Action, with a focus on the importance of integrating equity into perinatal care. Next slide. Southeast Michigan Perinatal Quality Improvement Coalition, or SEMPQIC, has a mission to create a coordinated, equitable, and sustainable network for perinatal care that's based on evidence-based strategies and best practices, working to improve birth outcomes for all babies born in Southeast Michigan, with a particular focus on narrowing the disparity between Black and white births, including maternal and infant outcomes. Next slide, please. SEMPQIC started in 2015 with funding from the State Health Department, Michigan Department of Health and Human Services, with a priority focus on improving health equity. We are Prosperity Region 10, which covers Wayne, Oakland, and Macomb counties, perinatal health system. Region 10 has, and we're one of 9 perinatal quality improvement coalitions across the state. Region 10 has more than 40 of the state's births, and more than 60% of Michigan's Black births are here. And we have wide disparity in birth and maternal outcomes, sometimes as high as 2 to 3 times worse than white outcomes. We work very closely with the State Health Department to promote the Maternal and Infant Health Improvement Plan for Michigan. And we focus on quality improvement by increasing home visiting services in our region. Our meetings convene 4 times a year, and we also sponsor workshops and trainings like this as they are identified by the membership. Every meeting has a health equity agenda item, recognizing that racism is the root cause of inequities. Next slide. This is a list of some of our work, and I'll just highlight the last 2 bullets, which talk about our work to improve maternal mortality by working with our birthing hospitals in the region to adopt the My Aim birthing bundles. And the recent funding we received from the W.K. Kellogg Foundation for the health equity, to develop a health equity network. We're in the 2nd year of that work, and we'll be releasing the website very soon. We also received funding from Merck for their Safer Childbirth Cities initiative that we're calling Project Detroit Voices for Life, which is working to reduce maternal mortality in the city of Detroit. Next slide. This gives you a sense of the diversity of our membership agencies. I'm not going to go through it, but we have about 60 agencies represented and usually have anywhere from 50 to 90 participants at our meetings. Next slide, please. To start, let's look at the CDC's Health Communication Gateway. This is a one-stop shop for health communications. Whether you work in public health or in the healthcare arena, this site offers information based on the latest findings about health communication. I want to focus on the health equity guiding principles for inclusive communication. Go back up to the top, Devin. And I thought it would be helpful to actually go into the site. That's what Devin has done. So you can see it firsthand and see how it's used. I will mention that all of my slides will be available for your reference after the webinar. Scroll down to the bottom. The site includes a tab at the bottom that takes you to the different subjects exactly. The principles emphasize the importance of addressing all people inclusively and respectfully. They're intended to help health professionals, particularly health communicators, ensure communication products and strategies adapt to the specific cultural, linguistic, environmental, and historical situation of each population or audience of focus. The guidance encourages application of the principles across communication work. including when creating information resources and presentations, when engaging with partners, or when developing and reviewing communication materials. The guiding principles address the specific aspects to consider in order to do these. And they include using a health equity lens when you begin developing materials. Okay, we can go back to the slides. There are 5 principles that are included in this guidance, one being using a health equity lens, when framing information, considering the key principles by using a person-first language, and I'll talk about that a little bit more as we go into it, avoiding unintentional blaming, using preferred terms that CDC has outlined that we'll look at, and considering how communications are developed when looking for ways to develop more inclusive health communication products. And it also includes a robust list of resources and references that you may find useful for health equity communications. Next slide, please. Using a health equity lens means working to avoid perpetuating existing inequities that exist in Black and Brown and other populations in communication. I thought putting the information that the guide had listed out in narrative form in a table on these slides might make it easier for our workshop today. Consider how racism and other forms of discrimination unfairly disadvantage people and lead to social and health inequities. Emphasize the value of ensuring that everyone has an equal opportunity for health. Explain the policies, practices, and services and environments that support health can reduce health inequity. Recognize that access to information is not enough. People need information they can understand. They need information they can use, and they need information that's culturally and linguistically appropriate. Avoid implying that a person or a population is responsible for increased risk of adverse outcomes. Recognize that some members of disproportionately affected groups cannot follow public health recommendations. These may be due to inequitable resource allocation or a lack of inclusive infrastructure. An example of that is quarantining at home when there's been a COVID exposure. A house with limited rooms may not afford that option for a large family. Consider ways to improve the accessibility of content, such as using alternative communication formats and offering materials in other languages. Next slide. This slide gives an example of applying a health equity lens for possible improvements in the visual. It came from a 2021 article by Fing and Squabish in the Stanford Social Innovation Review. The original article offered what you see here, and the authors suggest a more inclusive way to label the legend might have been using larger proportion of the Black population and larger proportion of people in poverty. Next slide, please. As you see here. They suggest, although the labels are longer and might not fit as neatly on the visual, they are more inclusive and respectful of people being represented in the data. When creating a visualization, think about how you would like to be described or represented with words. Here, considering empathy could have helped the data practitioners be more inclusive. Next slide. A second principle for using a health equity lens is to assure your communication recognizes and reflects the diversity of the community of your focus. Use language that's accessible and meaningful to your audience of focus. Tailor interventions and communications based on the unique circumstances of different populations, and emphasize positive actions to be taken and ensure that community strengths and solutions are highlighted and drive local public health efforts. Recognize that some members of your audience of focus may not be able to follow public health recommendations due to their cultural norms, beliefs, or practices. And analyze structural barriers, both present and historical, that need to be addressed to better serve different populations at different levels and within different contexts. Next slide, please. It's important to order. Here's another example from the Fing article that highlights an opportunity to change when communicating data. And it is important to order data purposefully. Often researchers and analysts present estimates in charts or graphs or diagrams in a standard and traditional format. Many of the large demographic surveys conducted in the US order race, starting with white and Black as the first two options. Similarly, male and female are far too often the only option provided to answer questions about gender. The groups that data researchers choose to show in the first row of a table or in the first bar of a graph can affect how readers perceive their relationship. Always starting with white or men, as in the example shown here from a US Census Bureau 2021 report, can make these groups appear as the default and give them outsized importance. Instead of using the ordering of groups provided in the data, consider some alternative presentation options. Does your study focus on a particular community? If it does, present that group first. Is there a particular argument or story you're trying to tell? If there is, order your results to reflect that argument. Can the groups be sorted alphabetically by population size or sample size? Don't let the underlying data make those decisions for you. Instead, make conscious, purposeful choices to present your data through an inclusive, equitable lens. Next slide. Be sure community engagement is a part of the process used for developing culturally relevant, unbiased communication, whether for health promotion, policy, or practice setting, or for research. It should be a continuous process that develops relationships and builds trust and should be a two-way process. Community engagement can have varying levels of community involvement, from outreach to consultation, to collaboration and shared leadership. Co-developed and co-produced items should be the goal. Be clear that the population and or the communities you want to engage and the purposes and goals of the engagement effort are clear. This starts with mindfulness and listening and continues with joint decision-making and shared responsibility for outcome. Consult community members on concept and message development in order to best understand what messages resonate and do not resonate with the intended audience. Invite people who represent your intended audience to review materials before finalizing and distributing. The engagement must be responsive to the needs, culture, and norms of the community that's defined by the community itself. Next slide, please. Health equity is intersectional. This means individuals belong to more than one group. The way people's social identities overlap should be considered to better understand, interpret, and communicate health outcomes. Members of population groups are not all the same in their health and living circumstances. Diversity exists within and across communities with variations in history, norms, attitudes, behaviors, lived experience, and many other factors. Be cautious in generalizing about a community. Race and ethnicity should not serve as a proxy for socioeconomic status and vice versa. And this is a change that I've noticed, because during my time working at the state health department, we often use socioeconomics, we often use race and ethnicity as a proxy for socioeconomic status. So this is worth recognizing. Next slide. CDC used this photo in this section as an example of the intersectionality of people. Next slide. And the last point for using a health equity lens is that people don't have the same level of literacy to read and understand. Use active verbs and plain language so that all members of your audience can understand the information. Recognize that while people may not be literate, they possess other life skills that enable them to lead meaningful lives and contribute positively to society. Acknowledge that many people with English as a second language are highly literate in a non-English language. Consider lack of digital access and literacy. Some people may not have access to technology, and others may not know how to use it. Next slide, please. The guide also shares key principles that I've included here. Note the site offers multiple examples that may go beyond what I've shown here in this slide, but I wanted to give you a sense of what is included in the document. To start, the first key principle is to avoid adjectives such as vulnerable, marginalized, and high risk. These terms are vague and imply that the condition is inherent to the group rather than the actual causal factor. Consider using terms and language that focus on the systems in place and explain why and how some groups are more affected than others. Also, try to use language that explains the effect. The guide does a good job of offering alternatives for the change proposed. And it actually is set up to give the language that has been traditionally used under, as you see under this column called instead of, with alternatives under try this instead. So instead of using vulnerable groups, try groups that have been economically or socially marginalized. Or instead of using high burden groups, especially for scientific publications, use disproportionately affected groups. Next slide. Another principle is avoid dehumanizing language. Use person-first language instead. Describe people as having a condition or circumstances, not being the condition. A case is an instance of disease, not a person. Use patient to refer to someone receiving healthcare. Humanize those you're referring to by using people or persons. Again, the table gives you a sense of the terms that have been traditionally used. And as I said, during my time working as the MCH director, we often developed documents that talked about diabetics or diabetes patients instead of using people or persons with diabetes to describe the information that we were presenting. Instead of using inmates, use people who are incarcerated, or instead of using victims, use survivors. Next slide. Use of the term minority and minorities should be limited in general and should be defined when used. Remember that there are many types of subpopulations. Be as specific as possible about the group you're referring to or the specific type of disability. Again, the table gives you the alternatives that are proposed to be used instead of what we've traditionally seen. Next slide, please. Avoid saying target, tackle, combat, or other terms with violent connotations when referring to people, groups, or communities. These terms should also be avoided in general when communicating about public health activities. Give some examples, communities with Black women who have poor maternal outcomes. And you can see the table again has the language that we are familiar with, that language we saw 30 or 40 years ago when we talked about the war on drugs and combating poverty. We really should be using it in language that recognizes the value of the people affected by the situation. Communities, populations of focus, intended audience. Next slide, please. Avoid unintentional blaming. Consider the context and the audience to determine if language used could potentially lead to negative assumptions, stereotyping, stigmatization, or blame. Do not assume that people are refusing or choosing not to participate in a behavior or access a service. They may be affected by access, acceptability, or other structural issues which are at play. And again, looking at what we may often see, people who refuse to be vaccinated, or workers who do not use personal protective equipment. Instead, we should be talking about it, workers under-resourced with personal protective equipment. Next slide, please. CDC is proposing a shift in the way we communicate about and to people intentionally, proposing non-stigmatizing language, and has included some preferred terms. Language and communication products should reflect and speak to the needs of the people in the audience of focus. This is not a total list of examples, but gives you a sense of the changes that are possible. And they have the categories on the far left with the traditional language that we're used to seeing, inmate, prisoner, with alternative language that could be used, persons who were incarcerated, or people with disabilities. Or instead of saying homeless people or the homeless, talk about it in terms of people experiencing homelessness. And you can read the full list, but the CDC guidance actually has more terms than what you see here. I will mention too that American Indian and Alaska Natives are the only federally recognized political minority in the United States. Tribes hold a unique government-to-government relationship with the United States. Next slide, please. Developing inclusive communications requires that you consider the following. Build a diverse workforce throughout levels, including leadership positions. Consider the benefits of hiring people from the communities you serve, including those who are disproportionately affected and who look and sound like the communities you serve. Work with community partners to identify priorities and strategies before the communication products are developed and released. Make sure you're including the need to build community awareness and acceptance. Avoid jargon and use easy to understand language. Ensure information is culturally responsive, accessible, and available. Information should represent people in the communities for whom the information is intended. It makes me think about the statement, nothing about us without us. Next slide, please. Some images are not understandable to people with disabilities. Emphasize the need for alternative text and ensuring web pages don't include graphics as the main source of guidance that cannot be understood by a screen reader. Avoid things like always using traditional or cultural dress images, showing any inequity with status in images like this picture, where we have a patient as a person of color and the authority figure or the doctor as being white, or you have a person who may be homeless shown as a person of color. You may also want to avoid images that perpetuate unhealthy body images or caricatures of any racial or ethnic minority groups. Next slide, please. Insufficient consideration of culture in developing materials may unintentionally result in misinformation, errors, confusion, or loss of credibility. Ideally, images should be created by communication professionals from that culture. Check the materials for some of the following. Are there words, phrases, or images that could be offensive or stereotypic of the culture or religious traditions, practices, or beliefs? Are there words or phrases that may be confusing, misleading, or having a different meaning for the intended audience? Are there images that don't reflect the look or lifestyle of the intended audience, or places where they live, work, or worship? Are there health recommendations that may be inappropriate for the social, economic, cultural, and religious context of the intended audience? And are the toll-free numbers or reference web pages included in the document in the language that the audience can read? Are resources such as teletypewriter or chat functions available? Material should be translated into preferred language of the audience with a native speaker, and a native speaker should review it once the material has been translated. Work with community members, leaders, and population-specific experts to develop and validate content. Next slide, please. Other areas of consideration includes considering whether the community of focus has the ability to follow the guidelines, work with established community leaders and community serving organizations to incorporate needs, priorities, and opportunities into the design of the public health interventions tailored for that community. Not everyone has a regular healthcare provider. Additionally, not everyone trusts medical professionals, so guidance to have and talk with a regular primary care provider might not be accepted. Hold on a sec. Access to medical and mental health care and needed services might be limited. Information should be made available in accessible formats like large print, Braille, American Sign Language, closed captioning. Ensure that equal access to public health services for people with disabilities and operation of disability services before, during, and after public health emergencies exists. The COVID pandemic has increased opportunities for people with mobility disabilities to access telehealth services, which previously were limited. Disparities in mental health outcomes are a public health issue that should be considered in addition to physical health outcomes. Consider that people might experience poor mental health outcomes due to multiple factors, including limited access to appropriate and affordable care, cultural and social stigma surrounding mental health care, experience with discrimination, and other factors. And age and associated risk are often a continuum. Risk for many diseases and severe outcome diseases risk for many diseases and severe outcomes increases with age, with increasing risk among middle-aged adults and older adults at higher risk. This recognizes the importance of intentionally considering who the focus audience is for the communication. Next slide, please. The guide also offers considerable resources and references with links for all of the areas that are listed here. And again, I've included the link to the resource for your own information. I'll pause here to see if there are any questions in the chat. If not, we'll move on. Next slide, please. Next, I'd like to introduce you to health equity material recently released by the American Medical Association that could be quite useful. I'll quickly highlight the strategic plan document that you see on the left of your slide and encourage you to explore it on your own. I'll review the guide to language, narrative, and concepts in more detail today. Next slide. The American Medical Association organizational, the American Medical Association, I've lost the slides, but I think that's okay, right, Devin? Organizational strategic plan reflects the work of the AMA over the past 3 or 4 years to address health equity. The organizational strategic plan to embed racial justice and advance health equity is a noteworthy document from the AMA, considering the historical practices of racism, inequity, and exclusion that has been a part of this organization for the century of its existence. The document references the previous practice of experimentation on enslaved women, often done without anesthesia and always without respect for their humanity. It also includes reference to the history of the practice of excluding Black physicians from the AMA and the exclusion of Black patients from quality medical care and better resourced white hospitals when segregation was legal. It also documents the more recent limitation of Black people to medical school admission and recognizes the need for and intention of the AMA to change to assure racial justice and health equity is integrated into the organization. The report, and Devin is just scrolling through the report to give you a sense of what's there. The report and recommendations were created in 2018 and adopted by policy by the American Medical Association Center for Health Equity. It was developed by the AMA Center for Health Equity, which was established in 2019, and they were charged with identifying ways to dismantle racism in the US health system, as well as facilitating, strengthening, and amplifying the AMA's work to eliminate health inequities rooted in historical and contemporary injustices and discrimination. The document includes a preamble. You may want to scroll back up to where that is, and a land and labor acknowledgement. The preamble and vision help to set the tone for the plan. The land and labor acknowledgement is a way of publicly and intentionally recognizing a history that includes taking land from indigenous people and enslaving Africans and descendants for labor. There's considerable moving narrative within the document, and it offers these quotes that we may have already scrolled through. We are all born equal, and health is our human right, along with the sentence I shared here for your reading. And I think it helps to demonstrate the sincerity of the American Medical Association. Devin, if you could go back to the slides, that would be great. Right here. Yeah, if you'll take a look at the quote that's included under health is our human right, it really does give you a sense of the sincerity of the AMA. It recognizes AMA's past and present power and influence in medicine and health and commits to accountability towards the goal of eliminating inequities, systematic, preventable, and unjust differences in health for patients, families, providers, and communities, as well as tackling the root causes for these differences and preventing new and further harm. It includes 9 points of equity-centered solutions, and the executive summary highlights the 5 strategic approaches adopted by the AMA with input from others. The strategic plan serves as a 3-year roadmap to plant the initial seeds for action and accountability to embed racial justice and advance health equity for all of our years to come. It is written as a vision for equity and justice in medicine. Next slide, please. I included these 3 excerpts from the document just to give you a sense of some of the history that's shared there. I'm not going to read them, but as I said, you will have copies of the slides and you can take a look at it. I think it will encourage you to take a look at the full document on your own and look at it, because it is quite informative and instructive. And as I said, I've included the web link for this document. It seems to be comprehensive. The strategic plan describes an authentic attempt at integrating racial justice and health equity into the American Medical Association. Next slide. Next slide, please. The American Medical Association and the American Association of Medical Colleges Center for Health Justice developed this 50-page document called Advancing Health Equity, A Guide to Language, Narrative, and Concepts, to provide physicians, healthcare workers, and others a valuable foundational toolkit for health equity. It's consistent with the AMA strategic plan I just mentioned, and includes a preamble as well as a land and labor acknowledgement as well. It includes recognition of the tribal nations in Washington, D.C., which is the headquarters of the Association of American Medical Colleges, and also recognizes the tribal nations in Chicago, which is where the AMA is headquartered. The document has narrative about the historical events that make up the journey of our country at the expense of indigenous people and enslaved people who've been oppressed and exploited for material gain. And Devin is scrolling through the document again, just to give you a sense of what's there. If you'll go back to slide 38, that'll be great. I shared this language from the document itself because it so moved me to think that the AMA and the American Association of Medical Colleges are committing to practice efforts of recognition and reconciliation in order to work towards health equity. Now I'll give you a minute to just read through it. Next slide, please. The AMA speaks of sharing this document with humility and recognizing that language evolves and being mindful that context always matters. The guide isn't designed to be a checklist of correct answers, but presented as a guide to stimulate critical thinking about language, narrative, and concepts, and helping readers to identify harmful phrasing in their own work and provide alternatives that move toward racial justice and health equity. Part 1 of the document is modeled after the CDC document we talked about earlier, using the guiding principles for inclusive communication. I'll focus on the latter part of part 1 and part 2 of this document, as there are several tables that I wanted to highlight which may be instructive and interesting. Part 3 is 20 pages of terms that I encourage you to review because they too are enlightening and offer definitions that may be useful. Next slide, please. Next slide, please. Oh, I'm sorry. Go back one. I encourage you to take time to read the entire document. It offers considerable encouragement to our work to advance health equity and maternal care. One of the first steps cited is developing an honest account of our deeply ingrained mental models and everyday assumptions about health and society. The AMA guide is intended to raise questions about language and commonly used phrases and terms, and the goal of cultivating awareness about dominant narratives and offering equity-based, equity explicit, and person-first alternatives. The guide notes that learning to notice and question dominant narratives is an important first step toward disrupting and correcting inequities and a vital component of health equity work. Next slide, please. Table 2 is included in the document, and you'll find a mix of 21 terms in this table. I've just included some of them, but it too is modeled to show what the common term is and the equity-based alternative that's being suggested is. And it also includes reasoning behind the use of that particular equity-based alternative. I think that is really instructional in helping us to move towards a more inclusive, equitable language. The main goal is to practice open and ongoing communication, awareness, and humility in order to refine language in pursuit of equity, not to provide a definitive list of incorrect and correct terms. And as I said, I've shown some of the terms commonly used here with the alternatives. I think having the rationale really is insightful. Next slide. Narratives can be considered collective stories or systems of meaning. Part 2 of the document shares how these stories are part of our everyday life and are our mental models, patterns, and beliefs. They matter because narratives of different individuals are used to visualize individuals and used to consider the questions that are asked to determine solutions for their health problems. For example, in a service delivery situation. One important way to make narrative visible is to consider the language that we use in our work. Shift to the use of an equity lens. Take, for example, the widely used term vulnerable population, a term often used to describe groups that exhibit increased susceptibility to adverse health outcomes. We even describe individuals as vulnerable or not vulnerable, often based on their socioeconomic status or neighborhood they live in. If we pause to examine our unconscious narrative, we can see that vulnerability can be understood in different ways. In this case, it's used as a characteristic of people or groups as something they have. Next slide. And within the document, you'll find this table that allows you to ask questions differently. The guide offers ways to determine different questions using the health equity lens. And I'm just giving a few of them. There's more in the actual guide in table 3. But what if we shift the narrative from an individualistic lens to an equity lens? That leads to questions directed towards the structural origin of vulnerability. For example, what interventions can address health disparities? What generates health inequities in the first place? How can individuals protect themselves? What kind of public collective action is necessary to confront health inequity across populations? So instead of stigmatizing individuals and communities for being vulnerable, we begin to recognize that conditions and power relations that create vulnerability. People are not vulnerable, they are made vulnerable. Next slide, please. This guide discusses how dominant narratives obscure historical legacies and harmful power structures that affect people's well-being. Dominant narratives serve to uphold social and economic relations that privilege some and marginalize others. They shape our thinking and assessment of the world around us. They determine who we see and hear and who needs are and aren't prioritized. Importantly, dominant narratives shape our understanding of what we deem possible and not possible. Here's an incomplete reproduction of Table 4 in the AMA, from the AMA document. And as it said, it's worth reading and considering from your perspective and how it influences the way we relate to the people we provide service to and engage with. And as you see here, the feature column reflects the dominant narrative used. Dominant narrative is all people and institutions of responsibility for social injustice. An example is the way the economic crisis is described. It really takes away all the blame from individuals and puts it on markets, mistakes, unfortunate events, rather than decisions and choices made by individuals and networks of power. If you look at that third example, dominant narratives are use coded racial language. The coded racial words and phrases like inner city, colorblind, states' rights, welfare queen, tough on crime, and government handout are used to denigrate public services that are needed and paid by all, but become associated with specific groups. Next slide, please. Table 5 is another table I thought was useful to highlight because it includes discussion of power dominant narratives to override viewpoints that work to imagine a more just society. When these narratives are closely examined, they lose some of the power they're created to reinforce. For example, looking at that first one, narrative, Native Americans have the highest mortality rates in the US. But if it is revised and looked at in terms of dispossessed by government of their land and culture, Native Americans have the highest mortality rates in the US. Take time to think about any personal narratives held about people, groups, or communities and how they were formed in your mind. These are a few of the examples used to compare conventional phrasing with equity-focused language, and more are included in the document. Okay, I'm going to go to the next slide. And the guide includes Dr. Kamara Jones' definition of race as a socially constructed way of grouping people based on skin and other apparent physical differences, which has no genetic or scientific basis. While in many aspects of medicine, race continues to be used as a biological concept. This diagram, included in the document, used with the permission of the Lancet, is very telling about how race has historically and even currently being used to influence research, medical education, and clinical practice. Work is occurring to take action towards anti-racism in medical education, including the misuse of race in medical training that promotes racial differences. Discussion of the narrative of individualism is also included, pointing out how this ignores the dynamics of socioeconomic privilege and racism. And if you look at the top portion of this diagram, you'll see how race ill-defined and inferred to have biological significance and how it was used across research, medical education, and clinical practice, as opposed to race defined as a social and power construct can then be used to reduce racial health inequities. Next slide, please. The document offers this basic guidance for practitioners to implement the changes noted. They are to think keenly, listen deeply, act intentionally, and reflect frequently. Part 3 of the document has 20 pages of key terms for reference that are also instructional. And I'll again pause here for a minute to check the chat before moving on to the last tool.
Yes, Alethia, there are a couple of questions in the chat.
Okay.
And this first one comes from Asma Khatib. When preparing presentations, you mentioned not including images that may not be able to be read with a screen reader. However, text-heavy slides can also be difficult for many people. How should we balance this?
There are tools that can be used to look for that. And though I can't cite them because I don't know exactly what they are, but I know there are tools that can be used to help review the material to make sure that it is accessible.
Alethia,
Yes, go
sorry.
ahead.
Teresa Holtrop gave a suggestion. She
Good.
says, I was always taught to try and include no more than 6 lines of typed slides to keep them more legible. This can be hard to do, but has been a helpful guideline to attempt to follow.
Great, thank you. Thank you, Dr. Holtrop.
She also made another comment, pediatrics that focus on inequitable approaches to non-white kids being evaluated for ADHD. The recommendation was made to change the verbiage from minority youth to
minoritized youth.
Yes, thank you.
Yeah,
So
yeah, actually, this was actually a sort of a question I have, because we were working on a resolution to be presented to the leadership of the American Academy of Pediatrics for consideration. And they wanted us to change, and actually it was the section on minority health equity and inclusion that reviewed this resolution and said we should change it from minority youth to minoritized youth. And I have to confess, I still have a hard time getting my arms around what that difference is. Does it sound better to you? And why does, if it does, why?
I can help. This is Vern. I can help answer that, Teresa. Minority youth makes them own the fact that they are minority, as opposed to they're only minority because we decided, that we are the majority and they are the minority. And if you say minoritized, it is more something that is done onto them, not who they are. So that
makes
it's a little
sense.
awkward, but that is the difference.
Yeah, and
That makes sense. Thank you.
And that term is also included in both the CDC document and the AMA document. And again, I think it also has to do with the fact that really, as I said, the only recognized minority group is the Native American population, at least in the US. And so as Vern has said, we've identified them as the minority as opposed to them actually being the minority. Other comments? Were there other, I'm not seeing the chat, so. Okay, I'm gonna try to finish the my overview of the last tool. Thank you. Appreciate those questions and comments. The next few slides that I'll talk about are from a free e-learning program made available by the Office of Minority Health, U.S. Department of Health and Human Services as part of the Think Cultural Health segment. Has anyone taken this course yet? And if you have, just put it in the chat for us so we can know that you know about it. This is a free 4-segment e-learning program. It offers 2 hours of continuing education hours for clinical providers. It's designed for providers and students seeking knowledge and skills related to cultural competency, cultural humility, personal-centered care, and combating implicit bias across the continuum of maternal health care. It focuses on the culturally, linguistically appropriate services as a strategy to improve quality of patient care. Oh, I'm sorry. CLAS cultural linguistic appropriate services refers to services that are respectful of and responsive to individual cultural health beliefs, practices, and preferred languages, health literacy levels, and communication needs. It should be employed by all members of an organization at every point of contact. At the provider level, providing CLAS means practicing cultural competency and cultural humility. And the training models the CDC CLAS guidance. Cultural competency is a developmental process in which one achieves increasing levels of awareness, knowledge, and skills along a continuum, improving one's capacity to work and communicate effectively in cross-cultural settings. As you learn and understand other cultural practices and values, your cultural competency increases. Where cultural humility is a reflective process of understanding both biases and privileges, managing power imbalances, and maintaining a stance that's open to others in relation to aspects of their cultural identity that are most important to them. It means taking time to understand the patient's culture, beliefs, and values with acceptance. You can go back to the slide, go to slide 52, Devin. The e-learning course offers a pretest and 4 sections of learning as noted in the right side of the slide. The covered information focuses on disparate health outcomes of Black and Indigenous people of color. It offers information about the history of medicine in terms of medical teachings and the practice of care. It covers how discrimination and consistent stress contributes to the weathering of women's health status as impacted by racism, sexism, classism, other isms, and the social determinants of health. And it covers information on implicit bias, microaggression, stereotypes, and intersectionality. Next slide. The curriculum does a nice job of reflecting the connection of the steps seen here and the influence on health along with examining the role of practitioners to mitigate these effects, looking at bias, stereotype, how it leads to prejudice, discrimination, and oppression using institutional power. Next slide, please. The course takes about 2 hours to complete, but the final module has a focus on a few of the terms that you see listed here. Cultural competency, humility, cultural humility, person-centered care, and it works to improve your quality of care by understanding, respecting, and responding to a patient's experiences, beliefs, and preferences. The module is easy to navigate and lets you stop and restart simply. Next slide, please. It's a great free resource for professional capacity development in the area of health equity for those working in maternal health care, and is available for physicians, nurses, pharmacists, social workers, and dietitians. And at the end of the course, if you desire, you can print the certificate of completion as you've seen here. I went through it. The agencies that are listed on the right have accredited the course. And as I said, I plan to use it. I am a dietitian and plan to use it for continuing education hours. Next slide, please. I've included a slide of recommendations as I wrap up. And really all the tools I've covered today are appropriate for settings where the population served is not homogeneous, which is Region 10, because our community is made up of people of diverse races, ethnicities, gender identities, religious and cultural practices. The CDC guidelines can be used by nearly anyone working to promote health equity, recognizing that communication is a major factor in that effort. The American Medical Association Guide is useful for medical providers, their support staff, health equity trainers or training curriculum content, and is great material for use with workshops or role play. And the Office of Minority Health Professional Development e-learning tool, as I said, is available, is a good use for docs, for physicians, nurses, social workers, pharmacists, dietitians, really any professional working in direct perinatal care, especially with Black and Brown populations. As I close, next slide, I've included a slide of our SEMPQIC leadership team for your information. If you're not familiar with SEMPQIC and would like to join our mailing list and begin to attend our meetings, we've included our contact information at the bottom. And next slide, end with this picture of a mom from our region who recently delivered this sweet infant, because all our work has a goal to help women have a healthy birth experience. These tools offer valuable information, if used, that can help make that possible for Black and Indigenous women who continue to experience poor maternal health outcomes in our community. Thank you. There is an evaluation. We will be checking the chat. And because I have gone over, if there are questions that we haven't been able to answer, we will, are there any, Lisa or Andrea? I was going to say we would work to make those answers available.
No, there weren't any more questions other than to verify if they would be receiving the slides, and we did respond to that.
Okay, great. I hope this was useful. Thank you again. Have a good afternoon. That's a good question. Are we going to stay on or are we going off?
I was hanging on just in
Okay.
case we needed to.
I was just looking through the chat. I couldn't really look through the chat while I.
Yeah, I thought it was excellent, Alethia.
Oh, well, thank